Good morning. I'm Lee Gervitz. I'm the head of medical for Biogen North America, and for more than a decade, Biogen has been working to transform the care of Alzheimer's disease, a chronic neurological condition. And today, if you're thinking about, there are more than 15.9 million patients that are living with mild cognitive impairment or mild Alzheimer's disease in the United States, and that's a number that's going to continue to grow in the coming years. Thankfully, the landscape in terms of the treatment for AD has changed, and we're now able to offer disease-modifying treatments and are opening doors through research. But there's a lot more work to be done. If you're looking every day, about 2,000 people with a diagnosis of mild cognitive impairment are moving beyond the point of being able to be helped with the latest treatment advances. Recently, Boston Globe reporter Jonathan Saltzman wrote about the experience of one family in finding their journey through diagnosis and navigating after that life-changing diagnosis. His reporting was a powerful and moving insight on some of the complexities of being told that you or someone you love is living with Alzheimer's disease. Today, Jonathan Saltzman is joined by Professor Rhoda Oh of Boston University, Dr. Garrett Friedman of Beth Israel Deaconess Medical Center, and Professor Vijaya Kolashalama of Boston University to talk about how the diagnosis and treatment journey are changing the Alzheimer's disease landscape. So please welcome them.
In the past year and a half, the FDA has approved 2 rival drugs that modestly slow the progression of Alzheimer's disease, including one co-developed by Biogen called Leqembi. But one of the challenges that medicine faces is to figure out who has Alzheimer's or is at risk for developing it. Our 3 guests today will discuss how scientists are working to get a diagnosis as early as possible. Dr. Friedman, you treat patients at Beth Israel, and you're currently prescribing Leqembi to some of them. How do you determine that someone has Alzheimer's in an early stage?
So it's a difficult diagnosis to make, and I think the way that the diagnosis of Alzheimer's disease is made is there's a right way to do it and a wrong way to do it, and unfortunately, I think the wrong way to do it is what happens more often. I'll talk about what we do, but there's a problem in terms of accessing this sort of pathway. So the ideal pathway is something like you see a person like me, and you've got some small changes that you don't really know if they're normal or not. You're losing your keys more often or something like that. You forgot your grandkid's name. You're feeling embarrassed by something like that. And we have a long appointment. We really try to get to the bottom of it. It takes a lot of time. We might do some crude testing. We do maybe 10 or 15 minutes of little tests to see what's easy for you, what's difficult for you. Is it more short-term memory, more visuospatial problems, things like that. We might do some brain imaging. We might put you through more testing, like a separate appointment. You do 2 or 3 hours of pencil paper type testing. And then if we want to be 100% certain to really make this diagnosis to consider one of these therapies, then we would need like a PET scan, like an amyloid PET scan or another sort of advanced test like a lumbar puncture where we sample the fluid that runs around the spinal cord. So that's a difficult process. And what really happens for most people who are in that stage where they're wondering if something's normal or not is they see their primary care doctor and they say that same story and they say, sounds normal, sounds fine, come back next year because you brought it up 15 minutes into a 20-minute appointment, and that's the system we have right now. So there's a lot of room for improvement in making this diagnosis.
And how widely available, depending on where you live in the United States, is the lengthy examination that you described?
It's barely available here, and this is probably the best place in the country, the world, to get it. The wait to get in to see someone like me might be 6 months alone. Going through that process might take another 6 months, so it's tough, and that's the best case scenario. So to use one word, it's tough.
Yeah. In the story I wrote, I actually accompanied someone with early stage Alzheimer's to Beth Israel for an examination. I didn't go into the examining room, but he did take a test called a MoCA test. Can you describe that and tell me what that is and how effective that is?
Yeah, so the MoCA is a test that most doctors hate because it takes a lot of time mostly. So the MoCA is the Montreal Cognitive Assessment. It's a test, it's one piece of paper, and it's basically a couple quick things like draw a cube, make a pattern, a quick memory test, 5 words, things like that. It takes 15 minutes, which to most people in their work life sounds like a short thing, but in the physician world, that's really cumbersome. We said a primary care doctor visit is 20 minutes, so you're basically taking up the whole thing. And it was made a long time ago, basically, on theory, not on a lot of data. It's not like it was made because it was proven out of 100 tests to be the best one to detect early Alzheimer's disease. So there's a lot of work left to do with that test for sure.
And how accurate are the results of that test? Can you say after giving someone that test, and I remember it's things like drawing a clock and counting backwards from 100 by sevens, how accurately can you say that someone does have Alzheimer's?
Very inaccurately if all you're doing is looking at the number. So if you make an arbitrary cutoff and you say, if you don't get a 26 out of 30, then that's Alzheimer's disease, then you're doing a terrible job. A part of the challenge is that every person is extremely different. I might see patients who never learned how to read. I might see patients with multiple graduate degrees using the same test and just giving them one number and saying, is this normal, is it not? Doesn't work very well. And it was never designed to be a test for Alzheimer's disease. It's designed as, a test of are you performing below some cutoff? And then you need to keep working. So it's not a very good test if it's your only test of, is this Alzheimer's disease?
And what role does brain scans play in diagnosing early Alzheimer's?
A lot of role. So an MRI is probably the scan that we use the most, or a CT scan of the brain. The old teaching with these was that we did this to say, is it something else? Is this a stroke that's caused your memory problems? Is there a tumor, or who knows what else? Now, in better hands, we can see those early changes in Alzheimer's disease or the short-term memory centers of the brain shrinking a bit, but usually you don't have a doctor who has that much experience, and so it's not glaring. Alzheimer's disease isn't going to jump off the page when you look at an MRI, but it's helpful in the right hands for sure. And then there's more advanced tests like the amyloid PET scan or FDG PET scan. Those are much harder to come by.
And when you say they're harder to come by, are they covered by insurance?
Complicated answer, but the short answer is no. The short answer is no.
Okay. Dr. O, you've done a lot of research into the development of better tools to diagnose Alzheimer's early. I wonder if you can tell me what kind of tools you're looking at.
Sure. I'm actually very interested in how digital technologies can change the way, as Garrett was saying, the MoCA is not a very good test, right? And so the question is how can we then find better ways to do it? And so one of the things that we've focused a lot on, and Dr. Colatom will talk a little bit about this as well, is we've started to focus on things like voice. And why voice? Well, it turns out speaking is a very cognitively complex task. So when you are talking, you're actually emitting your cognitive capabilities on an ongoing basis. And actually, for anybody who's ever had someone in their family with the early stages of Alzheimer's disease, you've picked it up, right? You've picked it up when you're interacting. You're not testing them, but you're monitoring how that conversation is going, and you're picking up these both acoustic and linguistic features that over time tells you something is going on. And that's what we're interested. We're interested in sort of figuring out how do we then take this kind of signal and find a way to objectively monitor it in order to use it as an alternative way in which to measure cognition.
What are some of the speech patterns that are maybe telltale signs what are you referring to? I mean, I can think of like aphasia off the top of my head, but I wonder what kind of patterns you're talking about.
Sure. So I think, and again, this is, you can kind of almost common sense think about this. You think about, oh, you have those hesitations, you have those pauses, you do what we call circumlocution, which is you can't figure out what was the word I really wanted, so I'll try to talk around it, I'll try to grasp for another word. I might have to use more words, I might use fewer words that are much more common, and I don't use as many complex multisyllabic words, I have shorter sentences. So there's a whole range of different patterns across what we call, both the acoustic and linguistic features that will give you that signal.
Now, how would this work in practice?
Yeah, I think, and we're in the very early stages, but one of the things that we've been thinking a lot about is how we can use the smartphone as a data collection tool. So I'd actually wonder if there's anybody here who doesn't have a smartphone, right? So this is the most penetrating technology in the world. 6.8 billion people have a smartphone, and we all know it can record your voice. So we're developing applications in which we can then collect this information and then using data science AI methods, analyze it, which I think Jai will talk about, in order to be able to extract sort of that something is coming. So imagine now that you can be able to do this on an ongoing basis as you're moving around your environment, both within your home and outside. And then we can use this sort of as a continuous monitoring system to start to pick up when these early changes might be emerging.
And is this something that a doctor who's doing a 15-minute test wouldn't likely pick up on? Is that too short a time?
I think in the primary care setting, I would definitely say that's probably too short a time. I think that Garrett mentioned, it's just normal aging, et cetera, just in that course of the conversation. I would imagine that a specialist with a short exam might be able to detect it a little bit better. But, this is very subjective. And as Garrett mentioned, Boston, we're lucky. We have lots of specialists. In most parts of the country and in the world, they don't have that. So this would be a tool that could help bridge those gaps.
Vijay, what role could AI play in helping to diagnose Alzheimer's? I think you could probably dive into some of the stuff that Rhoda just mentioned.
Yeah. Before I answer, I just want to provide some context. Just in terms of statistics, there are millions of people who are, I think, having these issues. We have about, I think, 20% shortfall of neurologists in this country. It's actually worse outside. For example, if someone wants to get an appointment with a neurologist in Boston, it's going to take about 3 months. So it's actually much worse outside Boston. So there's a lot of data that I think is being collected in a practical neurology setting, but I think Dr. O is also mentioning about collecting data from smartphones. So we are talking about a variety of different data here. For example, voice data that you can get from smartphones, MoCA tests, MRI scans, PET scans, CT scans, EEG recordings, all these cognitive tests that are being done. So it's basically a huge swath of data, multimodal data, that I think is being collected. And I think AI can actually help here to sort of analyze all these different data sets to sort of really pick those signals very early on. And I think in the previous panel discussion, somebody was talking about AI replacing specialists. I don't think that's actually the case. We should not even talk about that. That's not even a debate. In my opinion, AI can serve as a truly assistive tool to sort of streamline neurology practices and sort of bring efficiency, and not just in neurology practices, but also upstream, like in a primary care setting. Imagine again a patient walking in. Typically, first of all, no patient directly goes to a neurologist. Typically what happens is, you observe some kind of problem with the patient, the family care member sort of first gets an appointment with a family medicine doctor or a primary care physician. They go in there. The primary care physician may not have all the expertise. but they have the potential to collect whatever data that is available in their setting, which means, let's say, smartphone-based voice data or some other basic test like MoCA, I think you mentioned about it. And that's the data they have, and they have to sort of make a simple assessment based on that. So AI has to be truly be resilient enough to sort of process all that information and provide some kind of a suggestion to that primary care physician so that they can probably then refer that patient to the next step, which is maybe seeking an appointment with someone like Gareth, which is the one who has the expertise, the one who can actually collect more data and then sort of provide more care to that patient. So I think AI has a tremendous potential, especially in neurology, because we are in huge shortage of expertise. 20% is a huge number. We are talking about millions of patients waiting for months. And if you again, in these cases, especially with this neurodegenerative condition, if you're waiting for 3 months, it's already probably too late, right? So we need to think about how to sort of really bring these tools upstream in the care cycle, so that AI can truly be assistive here, not replacing it all. I don't believe in that in the theme at all.
How close are we to using these new tools, such as speech patterns and applying, and it sounds like applying a number of different tools, and then using AI to come up with some sort of an analysis?
So I think it's a great question. I'll talk briefly about it, but I'll let the experts also speak about it. First of all, I think in the neurology field, what I have observed is that we need to start collecting a lot of data. We don't have enough data to cover all these different spectrum of conditions, as well as the different settings, like starting from primary care all the way to tertiary care. And obviously, there is also the other segment, which is clinical trials, where I think AI also can help, but I want to talk about that later. But in generally speaking, I think we have to do a lot of studies to make sure these AI tools are resilient and robust enough to sort of really assist the clinician. I think we are on track in terms of building efficient AI systems, but they have to be tested in real time.
We do have some questions from our audience. To Rhoda, I love how you mentioned smartphone biomarkers of Alzheimer's. Besides voice, will you consider other modalities like an accelerometer for gait monitoring?
Yeah, I think that when I use the digital voice, that's sort of simplifying it. I actually personally believe that it's going to be multimodal. I don't think it'll be a single, I don't think that there's a single of anything. So I don't think it's a single sensor. I don't think it's a single modality. I also don't think it's a single pattern. I think it's going to be sort of the triangulation of all multiple sensors that are collecting information, including accelerometer, including GPS, including, when you're interacting with your phone, there's a lot of screen-based behavior that we're picking up as well. So I think it's that combination. One of the things to remember in a smartphone is that the average smartphone has at least about 27 sensors in it. And all those sensors, those are data collection tools from my perspective. So it's really picking up all the different kinds of sensory information and pulling that together. But I do think importantly, one thing to remember is when we get to this concept of a digital biomarker, it's not going to be the way we think of traditional biomarkers. It's not going to be a static signal. It's not going to be a static, cutoff score or anything like that. It's actually going to be something that's very dynamic and flowing and ever-changing. And so that's the complexity of what we're trying to figure out, is how do we now take this very multimodal, continuously changing patterns of information and yet come up with a very precision diagnosis. I'm optimistic. I think we'll get there. I just think we have to be a lot more creative in thinking about what it is that we're trying to do here.
I just want to add that AI is precisely where AI can help exactly in this situation, because we're talking about multimodal data collection coming in from smartphone. So I think we need to build those systems to be able to sort of catch the signal early on.
Another one of our viewers asked, how does hearing loss play a role in cognitive decline associated with dementia and Alzheimer's disease? Garrett?
Yeah, so by the numbers, I think it's something like, you could say, like, if we treated everyone's hearing loss perfectly, then there might be like 10% less people with Alzheimer's disease. Some people might look at that number and say it's because it's preventing Alzheimer's disease. Some people might say it's because you're doing a little bit better on the test because you can hear it, so we diagnose it a little bit later. There's a lot of things like this that we can modify, and it's tough to pick apart which ones are actually modifying the underlying pathology. Is it preventing Alzheimer's disease? And which ones are helping you do better on the tests? So it's harder for us to tell if you have Alzheimer's disease. It's a complicated relationship. I think it's more that, I don't think it directly modifies what's going on in the brain. I don't think it's directly going to slow down atrophy, but I think that it is an important one, especially because with all of your cognition and all of the way that you interact is, through hearing, through language, and if you're spending so much of your brain power basically on trying to decode what you heard, even if you're not aware of that, if you're just spending that extra effort, then you do a bit worse on cognitive measures, you do a bit worse with, interacting with the world and all the cognitive challenges you have in a day.
Given that the medications that are available so far only modestly slow the course of the disease, and they, as far as I know, do not reverse the disease, and they don't really even halt the disease. How important and what is the value of getting an early diagnosis?
I think it's extremely important, and I don't really think it's that modest. Maybe that's my personal take. The overall numbers you see thrown out there with these therapies is it slows progression by something like 30%. So no, it's not 100%, and that doesn't sound like a cure, but 30% when it comes to your brain and your cognition, that feels like a lot to me. 30% off of your coffee, not so much. But context, 30% feels like a lot. So I think it is important. That's on average, and we're just getting started here. I think where oncology was 50 years ago, if we only had one chemotherapy and we called every cancer just cancer, and we didn't stage it or grade it or whatever else, so it's gonna get, that number's gonna move up. And I think it will move up by doing a better job of making this diagnosis, of doing it earlier. One, it seems to be more effective the earlier you do it, and two, if you're, slowing this car down and the runway is longer for it, then it's a bigger difference that you're making. So for multiple reasons, the earlier we make this diagnosis, the better outcomes we'll see.
Yeah, I just want to point out that when we're talking about sort of the onset of the disease, it's an insidious onset process. And so where we transition from what we call normal, or cognitively intact, into the point of what we would call disease has been a moving target, because I've been in this field for a really long time. So I remember when mild moderate dementia was sort of the cut point. Now we're at the preclinical, prodromal preclinical stages, and now with the biomarkers we're moving into what we call asymptomatic. But we call it asymptomatic because the tools that we're using are still pretty crude, like the MoCA, for instance. So the idea here is if you get early detection in an insidious onset process, and you can start to detect changes that are pretty reliable now, right, in terms of, across the different fluctuations, you can actually intervene much earlier. And you can intervene in ways that are not always pharmacological. So we know that about 40% of risk for Alzheimer's disease is modifiable. And so the idea here is if we can catch it earlier on, right now what we might even consider still in the normal stages and intervene then and do even combinations of pharmacological and non-pharmacological, that's how we're going to potentially slow progression. And research shows that if you delay onset of symptoms by 5 years, you'll cut a person's risk for the disease by about 50%. So that's the objective. The objective is to get you through, life with being as cognitively intact for as long as possible.
In the very short time we have left, what are some of those non-pharmacological interventions?
Well, kind of heard these before. There are the lifestyle interventions, physical activity, right? Diet, smoking, alcohol consumptions. There's actually clinical trials being done both here in the US through the Alzheimer's Association, the Pointer Study, as well as worldwide through the Worldwide Finger Study, where they're actually doing that as a trial, having people undergo modifiable lifestyle risk factor intervention and looking to see how it's slowing progression. And then they're pairing it, in some cases, with, say, metformin, which is a treatment for diabetes, right? So in this way, we're finding ways in which to now mediate risk.
Well, we're out of time. I want to thank our guests for a stimulating discussion, and I encourage folks to stick around for other panel discussions at today's Future of Medicine Summit. Thank you.